Thank you very much. So hello everybody. My name is Neil. I'm Director for Experience Participation Equalities at NHS England, and I'm really delighted to be here. I always learn something when I come to the Royal Free. It's one of my favourite places to come, both the Trust and the charity, so I know I'm going to go away with more learning today. Now I'm going to use some slides because I'm not as good a speaker as Ruth, but also because I think it's quite interesting to look at some images. Can you see that clearly? This is the work of an artist called Emma Barnard. Has anyone seen Emma Barnard's work? She tweets as patient as paper, and I'd recommend following her. And one of the things she does is that she did a little project at Whipps Cross where she took photographs of patients before they were going to go into a consultation with an oncologist, and then when they came out, she would get them to draw on the image. And one of the reasons I like it is because so much of our communication in NHS is verbal. You know, we're always asking people to write things down. And actually people really like drawing, they really like images as well. And one of the bits of feedback she got from that project was how nice it was to communicate in different ways. And now this is a gentleman who came out of that meeting with an oncologist, and you can't quite see it. What the oncologist said was he thought that consultation had gone very well. He thought that there'd been no anxiety from this individual, that he'd understood what he'd been told, and he'd gone out in a pretty good frame of mind. What you can't quite see here is what he's done is he's drawn a cliff, and he's drawn himself falling off the cliff with the words help on it. It's really, I think, indicative for me. I like this image because it really shows that when we work in the service, we really don't know what people are thinking or feeling or experiencing, and we really do need to make sure that we're attuned and responsive and we're asking. And particularly when you think about the range of things that we're trying to improve. Now, this is the National Quality Board definition of what makes a good experience of care. What we're working to. I won't read it all out, but they're things that you'll be very familiar with about patients being active partners in their care, being treated as an individual with their needs, values and preferences respected, being recognised that I am the expert on me, communications preferences being tailored, etc., etc. This is really what I work in NHS to try and improve. And it's difficult because these are the things that we don't see very clearly if we work in the service. You feel them very acutely if you're a patient or a carer, as Ruth was saying. Sometimes they can be regarded as being the nice to have in the NHS. So we think we work very hard on improving safety, we work very hard on improving clinical outcomes, and we think these, they're important to do, but they're almost an add-on to that. And I think that the real message that we try and get across is that they're very important and they're equally important, which is what the National Quality Board says. And they are equally important because they really underline the relationship between the patient and the health professional. So if you get these things right, it's a basis for a good therapeutic relationship. If you get these things wrong, you undermine that therapeutic relationship, you disengage the patient and the carer, and we find that safety is compromised, clinical outcomes aren't as good. So they're quite difficult to see, and they can be quite hard to improve. Now, what we try to do in the NHS is really try to improve the frequency with which we're getting feedback from people. So in the last 5 or 6 years, we've moved away from a service which used to be quite dependent on surveys that were done every year that gave you results sometime after the event, and they told you often about an overall trust rather than a particular service. And what we tried to move towards is a situation where every team, every service is asking questions regularly about the people who are using those services through the Friends and Family test. But the point of the Friends and Family test is not the score. The point of the Friends and Family test are the comments that people make. So how good was your care here? Why do you tell us that? Is there anything that we could improve? And that is designed to get at the kind of points that we're hearing earlier, where if there's great care from people, tell us what it was so we can do more of it. And if we've done something wrong, communicated in the wrong way, tell us and we can learn from that and we can improve. So the idea is you change it from a situation where we give the hospital information about its how people are experiencing its services towards those individual teams. and it does work. But one of the challenges with it is it amplifies some voices and it disguises others. Now, this is a Muslim lady at the Whips Cross 2, and what she wanted to do, she wanted to be photographed from her back, and you can't see it. What she's written this on the image is time to listen. And I think that really summarised one of the key messages for me, because what we're doing, I think, with feedback is we're giving a lot of people a stronger voice on issues that affect a lot of people, but we are disguising things that affect smaller numbers, and sometimes we're missing them altogether, and we have to work hard to compensate for that. And I think it matters, because this is what we can do with the data. Now, this is from the Cancer Patient Experience Survey. People familiar with that? Yes, anyone familiar? A few people. So the Cancer Patient Experience Survey is one of the best improvement tools that we have got. So 66% of everybody with a cancer diagnosis fills this survey in every year, which is a huge response. And you think about responses to surveys, they're often under 10%. 66% of people with cancer fill this in every year. And because of that, we really can drill it down. And this is data that we make available, but it shows that consistently BME experiences are poorer than white British experiences. And I think this is important for a number of reasons. First of all, that one of the key messages that we at NHS England are trying to get across in relation to patient experience is that we shouldn't get lost with the overall percentage of people who say they have a good experience. We really need to understand the variation between those who say they have a good experience and say those who have a poor experience, and understand what's driving that poor experience. It's actually the differences in people's experiences of care are probably more important than the overall figure for what it's telling us. But I think this slide is also important because it shows that the power of data. And we know we've got some catching up to do in terms of improving BME experiences, but what we can show with the Cancer Patient Experience Survey is that the majority of NHS trusts improve year on year, and they improve against the majority of indicators that we measure. So by measuring people's experiences of care, we actually lift the bar year on year, and the challenge for us now is to close the gap between those who are getting a good experience and those who aren't. So it goes back to the question about where have we got the gaps and where do we have the data. And I think in relation to race, we've got some of the best data, and we need to use it more to bring improvements about. I think in relation to LGBT, we have clearly got some gaps. And one of the things we really need to prioritise doing at the moment is using the sexual orientation monitoring standard, which was launched last year, which was the result of long-standing work within the LGBT community in order to provide us with some of the data that enables us to do some of this. So I think it's important to recognise there is some data available. There is data in a lot of the national surveys about sexual orientation which we can use, but we need to have better data in order to get ourselves on a path where we're really seeing what is the difference between people's experiences and how can we, where are the particular areas we need to prioritise and how do we try and remedy that. But the data isn't enough on its own. So data is important in quality improvement, but it's not sufficient for quality improvement. So data will tend to tell you what is happening, but it won't tell you why it's happening, and it won't tell you what's important and what's less important. And this is where involvement and participation becomes really important. And I think there is an expectation now that people being involved is part of having a good experience, but also involving patients is one means of understanding and improving services. And I think we have to constantly challenge ourselves as the NHS to say when we are involving patients, and it's not something that we naturally do well. I think there's a strong desire for the NHS to be better at co-design and co-production. And there are tools like Always Events and others which enable us to do that. But when we are working together with patients, who do we have in the room? And do we have a representative group from the people who are using our services? And often the answer to that is no, we're not. We had a conference last year organised with a number of BME organisations of people who told experiences of when they walk into the room, they're often the only black face there. They find that really a difficult experience and a marginalising experience, and we need to do better. So I think we've got a dual challenge there, is how do we get better at co-design and co-production, and when we do, how do we make sure that we've really got diverse participation in the room, because that is one of the key ways of adding to the data and making sure that we're trying to improve. Now, I'll give you an example of one of the things we're doing. We've got an initiative that we have been piloting and we're looking to launch soon, which is around learning disability and involving people with learning disability. Now, the underlying statistic there is that 4 people with learning disability die every day from a condition that we could have diagnosed and treated. So we know we've got a significant problem. But what tends to happen is we can be quite good at understanding the experiences that people with learning disability have of learning disability services. But that's not the point. The point is we really need to understand the experiences of people with learning disability of mainstream services so that we could do something to improve that. So what we're developing is a program called Quality Checkers. Are people familiar with Quality Checkers from social care? This is basically where you get people with learning disability who work in social enterprises. Usually they go along to visit a service in a neighbouring area, they talk to the people who use those services, they find out what's good about them, they find out what needs to improve, they write a report for that service, and then they come back 3 or 6 months later and find out what's happened. So it's usually used very effectively in social care to try and improve those services. It's used very sparingly in the NHS. Not many trusts have used it, and those that do have used it on a quite a small scale. So our hope is that we will be moving to a situation where that is used on a much more widespread basis. And what we're doing as part of the long-term plan, which I think really importantly is trying to broaden our ambitions on learning disability, moving us away from only really looking at moving people from inpatient settings into community settings, and giving us a challenge about what are we doing about those high levels of premature mortality, how are we making sure that services are responsive. Is that we're putting something into the NHS contract which is going to be looking at what organisations, NHS organisations are doing to listen to and involve people with learning disability in quality and quality improvement. And quality checkers will be one of the things that we're recommending that people do. Now, I'm giving that as an example of how we try and compensate when we don't have data, because people with learning disabilities are obviously some of those people whose voices are disguised when we do things like the Friends and Family Test, which results in large amounts of feedback, but usually not from them and not about their experiences. So there are areas where we need to compensate. So I think it's one of the important conversations to have within an organisation about what data do we get and how can we improve it. How do we have diverse conversations that help us to understand that, make sure we're talking to all parts of the community and involving them in quality improvements. And where we're struggling with that, are there initiatives out there which can help us to learn and do better? Now, one of the things I was involved in was I was the SRO for health and equalities in the long-term plan. And I think this is a natural follow-on from the previous conversation, because the NHS will not get anywhere tackling health inequalities unless we really start our conversations with people who are experiencing those inequalities and people within that who are some of the most marginalised and seldom heard voices. And I'm pleased that the new NHS long-term plan has a very significant and ambitious commitment to trying to do something about those health inequalities. And if you just need to compare what was said on this subject in the 5-year full review, where it's touched on but it's not central, to the long-term plan published recently, where it's got a whole chapter to itself, but it's also a strand running through the whole thing. Now, within that, we have to be realistic, because we know that the NHS on its own can only really touch about 20% of the inequalities that people experience. But those are important to try and address, and we can do a lot more with that, and we can particularly do a lot when working with partners locally. So I just want to reflect for a minute about how health inequalities are featured in the long-term plan and what that means for LGBT and wider inclusion. So they're included in the plan both in terms of the national programmes and they're included in the plan in terms of what we want local systems to do. And I think both of those are important. So in relation to the national programmes, there is an overall focus on what are the main causes of ill health and how well are we doing at diagnosing and treating people quickly so that people get good outcomes. And so there's almost a golden thread in the plan which looks at what those particular factors are. So in relation to the causes, very strongly in relation to smoking, alcohol and obesity. As the things that if we tackle those, it will make the biggest difference in terms of health inequalities. And then a bit further on, once those conditions are developed, looking at cancer, stroke and heart disease. And those three conditions alone represent about 50% of the gap between those who are getting the poorest outcomes and those who are getting the best. Now, there is some relevance to this in relation to the LGBT agenda. So if you take what we know about smoking patterns, for example, LGBT community has a smoking rate of about 24%. Compared to 16% in the straight community. So there's a significant added risk there that we need to think about, and we need to try and talk about what we're going to do about and how do we try and bring that down. Now the goals in the long-term plan have been written with an idea to try and really focus minds on the differences and experiences and difference in outcomes. So, give you an example of that in relation to cancer, the goal that we're signing up to is to diagnose cancer for 75% of people at stages 1 and 2. And that's a very significant ambition. There are parts of the country at the moment where about over a quarter of people who are diagnosed with cancer are diagnosed in an emergency admission. So it's absolutely clear that in order to achieve that goal of 75% at stages 1 and 2, we really need to understand who are those people who are being diagnosed late, why they're being diagnosed late, and what can we do to adapt screening services, to adapt our work to be much more preventative and much more engaging. And we can only do that by starting the conversation with some of those groups. Now, what the long-term plan is doing at the programme level is saying, these are the priorities, these are the things we need to work on. The big challenge is how they get adapted in practice. And we absolutely know that generic approaches that we can think about at the national level will not work for all of the different communities that are currently receiving poorer experience and poorer outcomes. So the central question that we're going to be asking next in the long-term plan is, what do we need to do to adapt these national programmes for different communities to make them work better? And that will be as true of the preventative programmes like the work on smoking, alcohol, etc., as it will be in things like screening for cancer, lung health checks, diabetes checks, etc. But the intention should be that the focus on this will make a big difference in terms of the poorer outcomes that people are experiencing. Now, what does that mean in terms of specifically the LGBT agenda? You'll be familiar with these figures, but we know that there are some clear areas where people from the LGBT community are facing significant inequalities, particularly in relation to higher rates of mental health problems and substance abuse. That those needs are not consistently matched by responsive services. People are reporting a negative experience, a range of negative experiences when accessing healthcare, as we heard. There's very long waits for gender identity services, etc. So there are some challenges there, as well as some achievements. So we do recognise that there's been a substantial decline in HIV diagnosis, for example. So that's what the data is telling us at a national level. The plan gives us a route to doing something about it. So in relation to mental health, for example, we are expecting there to be 345,000 more children and young people able to access mental health support. A key part of that will be through new mental health support teams in schools and colleges, greater capacity within university, as well as 380,000 more adults being able to use IAP services, a particular focus on suicide prevention, testing 4-week waking targets. There were some specific commitments as well in the planning guidance about speeding access to gender identity services as well. So again, the funding, we hope, will enable this to happen. The question will be, how do we make this work for the LGBT community? And that can only be done through conversation. And those conversations, I think, will happen at a local level about what do we need to do here in order to make this work. But hopefully, this is going to result in us targeting particular areas where we know that the community is experiencing poor outcomes. Now, just wanted to touch on the fact that one of the things we heard in engagement for the long-term plan is there are people who are considerably more marginalised within every community who've actually got quite a lot of common with each other. So we had a couple of sessions in the long-term plan talking to former homeless people, for example, sex workers, refugees, and others. And they particularly wanted us to focus on a number of things to improve their experience of the NHS. Part of that was about how do you get into primary care, and people reporting prejudice and discrimination so they couldn't get through the door, and we need to work on that. There was also a real conversation about how do you personalise care effectively to make sure that people really understand the effects of trauma, but also, on the other hand, understand the qualities and the assets that people bring as individuals. So when you look at the detail of the personalised care plan, which is looking to really extend our personalised care model to another 2.5 million people, it really takes that into account. And one of the things I'll be looking for it to do is particularly for it to focus on those people who have been often particularly marginalised, often because they've got a number of different protected characteristics and other experiences which have left them with trauma and very difficult circumstances. Now, I'm just going to say a little bit about the staffing and volunteering agenda. You'll know that we've been working to try and improve the number of BME people working at senior levels in the NHS through the Workforce Racial Equality Standard. We've also started to work on the Workforce Disability Employment Standard, which is looking at the employment of people with disability at similar levels. We've got some work that we've been doing for a number of years in different areas about people with learning disability employed in the NHS. I think the challenge for us over the next period of time will be to look at how do we move from some very significant and ambitious initiatives around race in particular. How does that drive inclusivity more generally? Because at the end of the next 5 years, we need to not only achieve the RES goals, but we need to see the NHS workforce, particularly at a senior level, being much more representative of the communities that we serve. So one of the questions we've got is how do we move from what at the moment has been a series of initiatives in different areas of inclusion into something which is more generally inclusive, that's going to lift the bar for everybody. So we're having that conversation at the moment. And we're also having a similar conversation about volunteering, and the Royal Free is brilliant at volunteering. I've always enjoyed coming here and meeting volunteers and seeing what they do. But we do have a challenge, and this is from the Centre for Ageing Better, that people who volunteer tend to come from particular parts of the community, and actually the people who would most benefit from volunteering tend to be the least likely to do it. And so one of the things we're going to be looking at over the next period of time for the NHS is what's the diversity of the volunteer base within organisations. And that's particularly important, I think, for the volunteer as an individual and what they get out of volunteering. And in some parts of the country, that is extremely important in terms of giving them a route into employment, a route into building skills, etc. But it's also important for the NHS because if we engage a diversity of volunteers, we will connect better with our local communities, we will understand them better, and it will be a route to being more responsive because we will be hearing frequently about what is working and what isn't working, and it will be a particularly important means of raising quality. So to conclude, the long-term plan, I think, gives us a step change in focus on health inequalities. And it will mean that every health system will need to come up with a plan that is going to reduce the health inequalities on its patch. In order to do that, it needs to understand its population, it needs to talk to groups of the population that we seldom hear, We need to understand what it is that's driving the equalities here, and how do our generic approaches to improvement need to be adapted to suit those different communities. And people will be held to account for that. So we've been very clear that CCGs will be expected to say what they are doing for the money that they're getting in terms of unmet needs and health inequality. The local integrated care systems will be looking at individual neighbourhoods to see what can we learn and how can we try and improve the consistency of outcomes and engagement. The focus of the national spending and the national programmes should really help to drive that up in the areas that make the biggest difference for health. But we've only just started the conversation. So I think this is an opportunity. What I'd really encourage you to do is to engage with the national improvement programmes where you've got an interest, looking at cancer, diabetes, mental health, etc., but also particularly engage with the conversation that's about to start locally about what does this mean here. How can we learn from the LGBT community about what needs to happen, where we need to focus, and what will make the biggest difference over the next 5 to 10 years. So I think quite exciting, but a lot of work still to come. Thank you very much.